And thank you very much for the invitation and being allowed to contribute to the Congress and visit this wonderful city. Right, what I'm hoping to do in 20 minutes or so is to go over the classification and perhaps stop and take stock as to how the classification has evolved over the last 10 years and ask questions more than just being critical. And we'll try to make it interactive, and every now and then I'll be asking you to tell me what you think of a given point, and just have a show of hand and see how we go along. And we'll focus ultimately on the latest classification, the KDIGO 2012. There's a hell of an echo. And look at some aspects of the classification. See how the classification came along, and ask questions and see some points that remain challenges and opportunities. And I'll go through the 5 what. Some of you who attend our master classes and teaching are familiar with the 5 what. One of the questions we need to ask ourselves is, what is the purpose of the classification? What is the validity and the strengths upon which some of the data are formulated? What is the usefulness to the bedside and to the patient and us as jobbing nephrologists for the classification, risk benefit and cost benefit? But perhaps I'll focus on 4 points. I'll ask these questions. Microalbuminuria in isolation, is it sufficient to define somebody as suffering from CKD? I think we're going over this point, but to my mind that is an important point, bearing in mind that it constitutes about 40 to 60% of people defined as having CKD. Do we have enough tools, there's enough formula? And I'm sure Andy will follow on by talking about the different formula. But as it stands, can we distinguish CKD 1 and 2? And is there a value in distinguishing CKD 1 and 2? Can age be ignored in the classification and adding EGFR or albuminuria? I'll focus on albuminuria. Does it improve our predictions? So these are the 4 points that I'll do. Just before we go there, let's try to figure out and remind you how we went from classification of 3 categories to 18 categories. Many, many years ago, and the older members of the audience will remember when we used to classify chronic renal failure as mild, moderate, and severe. And life was very simple then, and you had roughly the estimated GFRs. Then in 2002, KDOKI started the process of refining the classification, and we went from 3 to 5, and you're all familiar with the 5s. And bit by bit, we moved to 6 by splitting CKD3, for the simple reason that we all came to realize that CKD3B has a much worse prognosis than CKD3A, and so therefore it is justifiable, as it was discussed in the UK and formalized with a nice guideline, to split CKD3 into A and B. And as we all know that proteinuria is relevant to the progression of CKD in referred CKD in the patients we see in the clinics, NICE added, the UK guidelines added a P, so you've got 3 and A, 3B, as well as P if the level of proteinuria exceeds 0.5, or dipstick positive proteinuria. We got used to that classification, we tried to work with it. Came along considerable work done and led by KDIGO and by Andy Levy in particular and his colleagues, which showed us through a huge number of cohorts put together and analyzed that there is a correlation and a linear relationship between the severity of albuminuria, albumin-creatinine ratio, and not only the progression of CKD, but also cardiovascular, as well as all-cause mortality. And also the further you get decline in GFR, the higher your cardiovascular and all-cause mortality. So we came to realize that albuminuria and declining GFR are independent risk factors comorbidity, cardiovascular mortality, and all-cause mortality. And this led to the classification you now all familiar with. KDIGO came up with it 2012, and again we're privileged to have Paul Stevens, who led the group, who came up with the recommendation. We've got the 6 GFR categories, 3A and 3B, and now we have 3 albuminuria: normal, micro or low-level albuminuria, and overt proteinuria or albuminuria. And conceivably, we could add more, because there's very little doubt that age is a factor, blood pressure is a factor, and the trajectory and the course, progressors or non-progressors, also are important in defining the course and the prognosis of a patient with CKD. So we could end up with somebody who is G3A, A2, blood pressure controlled or otherwise, progressor or non-progressor, and so on. And it's just stretching the argument. So 10 years on, let's stop and take stock and ask these questions that many of you may have asked, and we can revisit. First, is microalbuminuria sufficient to define CKD 1 and 2 in isolation, making up 6 to 7% of patients in the community with CKD having low-level albuminuria, dipstick negative. Take this example: 75-year-old, not diabetic, systolic hypertension as you would expect from a 75-year-old, normal GFR, albumin creatinine ratio of 100 milligram per 24 hours. So a show of hands, who in the audience will tell this patient that he has CKD? Who will not tell this patient that he has CKD? Yet, it is a definer of CKD. I have my doubts, for the simple reason that an awful lot of conditions, I have my doubts that microalbuminuria is specific for CKD. If you're getting older, you have a higher prevalence of CKD. Inflammatory bowel disease, smoking, obesity, infection and inflammatory conditions. All these conditions, atherosclerotic, vascular, inflammatory, are associated with microalbuminuria, often transient and reversible. So for me, to a large extent, microalbuminuria is a sign that there's something wrong with you. It's the urine ESR, sedimentation rate. A few years ago, Amino Mella, who's in the audience, analyzed data from PREVENT and looked at people with microalbuminuria, followed them up for 4 or 5 years, looked at who lost weight. And those who lost weight also lost the microalbuminuria. But by multivariable analysis, multivariate analysis, there was no doubt that changes in blood pressure impacted considerably on the effect of weight loss on albuminuria. But moreover, changes in inflammation more or less explain the majority of the regression in albuminuria. So you could say that microalbuminuria is the urine CRP. So I think we made this point and we move on, and I think the majority of you, as clinical nephrologists, don't think that microalbuminuria on its own is sufficient to define CKD. And if that is the case, we could reduce considerably the prevalence of CKD in our communities if we take out the concept that microalbuminuria on its own, in isolation, is a marker of chronic kidney disease, be it stage 1 or stage 2. Let's come to stage 1 and stage 2. And here I'm a bit nervous to speak in front of the master, Andy Levy, who will talk about the different equations. But the problem we have is we have, in my mind, an artificial distinction between CKD and CKD 1 and 2 based on estimated GFR. When really we still don't have the tools. Originally we relied on MDRD equation. 1999 MDRD equation, 4-variable MDRD. More recently, the guidelines tell us to rely more on the CKD epi equation. And Andy will talk about these. But the point remains that neither equation is fully accurate and precise. There's no doubt that CKD epi is less biased than MDRD. In other words, the difference between measured GFR and estimated is less, perhaps 20% with MDRD, down to 11 or 12% with CKD epi. But the fact of the matter is, they're still inaccurate enough not to be able to distinguish a patient whose estimated GFR is 60 or 70 or 90, whether it's anywhere between 60 or 150. And more important, what's the point of that distinction? If you look at the prognosis in relation to GFR and all-cause mortality from 120 all the way to 70 or thereabout, and on cardiovascular, no difference. If you look at the new classification, whether you G1 or G2, it's albuminuria that drives the risk, not G1 and G2. So the question we have to ask ourselves, why distinguish G1 from G2? So the next voting point, are available eGFR formula accurate enough to distinguish between CKD1 and 2? Who thinks they are? And we may hear arguments in a few minutes that they are. So far, who think they're not? Show of hands. Okay. Let's move to the third point, age. Age has been contentious for a long time whether it should be or should not be taken into consideration. And Professor Glasek, who's again present with us, led, along with Chris Winnell, this argument. One thing we need to bear in mind, and it will come at the end when we talk about the purpose of the classification. I've put C here for community-based CKD, and I've put R for referred CKD. But when we look at community CKD, the 10 or 15% in the community we can hear about, we keep hearing about suffering from CKD, the majority are over the age of 50. Paul Stevens did similar work in the UK, and again, the majority of the prevalent CKD in the community is over the age of 55 and 60. So as we age, we develop CKD, or as we age, we have a decline in kidney function. I won't get into the argument whether it's physiological or pathological. The fact of the matter is the majority of us will lose around 0.7 to 1 mil per minute per year after the age of 50 in terms of GFR. And those who lose more GFR with time may be those with comorbidities, such as underlying hypertension or diabetes. Subjects without comorbidities seem to have a fairly stable creatinine clearance in this instance over time. So we suggested a while ago that with aging, comorbidities, diabetes, hypertension, lead to vascular damage within aging individuals within the community. Vascular aging will lead to end organ damage, including cerebral, cardiac, and renal. So the argument there will be, yes, with aging we lose function, but it is a function of aging and vascular aging, and CKD is a manifestation of vascular aging. And some colleagues started to come up with prediction equation for CKD, incident CKD within the community. There are other equations for referred CKD. This, we look at incident CKD 3A. And you see that the majority of the risk is cardiovascular. Hyperage, hypertension, diabetes, peripheral vascular disease, and so on. So if you have an increasing number of vascular risks, you have an increasing likelihood of developing CKD with age. Back to the age factor. Because it does matter when we look at prognosis. Are these two similar? 80-year-old with eGFR of 45. Vascular aging, age-related decline in kidney function. 25-year-old with the same GFR due to chronic glomerulonephritis. Can we classify them along the same rank or grade? Not only in my opinion, no, but also prognostically, they are likely to have different course. The younger patient is likely to progress to ESRD. The older patient with the same GFR is likely to die from cardiovascular disease before he reaches end-stage renal disease. So we're looking at two different categories. We're looking at referred CKD in a young patient. We look at community CKD, which is a vascular problem in an older patient. So, third question to the audience. Can age be ignored in any CKD classification? Who would say yes? Who would say no? Okay. I'm doing well so far. I never thought I'll do so well. Right, let's carry on. The last point, adding albuminuria to standard prediction scores, does it add anything? We know that the majority of community CKD, we've just seen it, are in the elderly. We know that they're more likely to die than reach end-stage renal disease, and they're more likely to die from cardiovascular and vascular complications. I think we all agreed there. There's no doubt that ACR, albuminuria, and GFR are independent risk factors on their own, by their own right, for cardiovascular mortality and all-cause mortality. But what happens when you add them to well-established, simple vascular prediction scores? A review by Chang and Krim a few years did just that. It's a busy table or busy figure, but I'll take you through. Primary outcome, cardiovascular morbidity and mortality. They looked at the predictive value of standard Framingham risk score type of variable. Age, diabetes, hypertension, smoking, dyslipidemia, and so on. Looked at ROC curve and area under the curve and prediction, 76%, 82%, and so on. And then added albuminuria, cystatin C, eGFR, and found that it made very little difference in most of the studies they looked at. More recently, the PREVENT group with Ron Gansvoort and Dick Dezou did exactly the same analysis in patients within the community with low risk and preserved renal function. We know that albuminuria increased risk of mortality and cardiovascular complications. They applied the Framingham risk score, added eGFR. It did not reclassify, it did not increase the risk prediction. Added albuminuria, and it marginally increased the risk prediction by 0.03%. It was statistically significant, but is it really clinically significant? In a higher risk group patients, Catherine Claes did exactly the same analysis. Low cardiovascular risk, intermediate cardiovascular risk, high cardiovascular risk. Percentage patients in each category, added eGFR and albuminuria, no reclassification, no change in the categories whether you have albuminuria and eGFR compared to standard Framingham-style prediction scores. So they concluded that adding eGFR and albuminuria adds little to traditional cardiovascular risk factors in stratification of cardiovascular risk. Of course, it added prediction of renal outcomes. So let's briefly have a look at the validity of some of the assumptions and the studies we built our assumptions on, and the usefulness of some of these.
two recent systematic reviews. The first one from the Aberdeen group in the UK that looked at a number of cohort studies defining the prevalence of CKD and looked at quality criteria and see if they were achieved, open circle, or not achieved. And you can see that the majority were not achieved, with the simple reason that the majority of the cohort studies we built a lot of assumptions on only tested once and therefore does not establish chronicity. More recently, Tangri and Andy Levy in Boston looked at prediction and predictors, equation and risk stratification and the various studies predicting kidney failure, all-cause mortality, or cardiovascular events. They looked at the validity and the quality of these studies, and if there is a risk of bias, it's positive, and the majority of these studies, for one reason or another, had an element of bias. Lack of external validation, randomization or follow-up bias, attrition bias, and so on. And they also looked at the usefulness. Based on these predictors, including equations with EGFR and albuminuria, is it clinically useful? Not useful is minus. With very few exceptions, the answer was not useful, or not yet useful. And they concluded that whether the addition of proteinuria or newer biomarkers such as cystatin C or FGF23 will further aid risk stratification for cardiovascular disease in CKD is unknown and should be investigated. So that's a very important research question, because we may have the models and we may have the tools, but we haven't fully evaluated them yet. Now let's go back to the future. Let's come down from 18 to 3 or 4 categories. So if we start from the argument that albuminuria is not proven yet to discriminate outcomes, as stated by Andy and his colleagues in Boston, then perhaps we shouldn't have all these categories. And we'll see what are they for. Are they to predict ESRD and CKD progression, or are they to predict cardiovascular risk? And this will be my last slide in a minute. And why don't we revert to the proteinuria negative or proteinuria positive? We've known that referred CKD, if you have proteinuria less than 1 gram per 24 hours, your progression is slow, intermediate, and if you're heavily proteinuric, you progress fast. And again, that's the difficulty in one formula trying to cover progression of referred versus community CKD. We know from the work of Tazeen Jafar and many, many others that again, the 1 gram per 24 hours is important. No progression if you're less than 1 gram, more or less regardless of your systolic blood pressure. Relative risk of progression increases with blood pressure if you have proteinuria more than 1 gram. So I put it to you, why don't we divide and go back to the more than 1 gram, less than 1 gram, and the CKD categories. If CKD 1 and 2 distinction is not currently justifiable as you voted for, then we have to merge CKD 1 and 2. What's the point of having these two if we can't distinguish them with the tools we have, and if they make no difference in terms of prognosis? So I put it to you that we might as well have, in patients with GFR higher than 60, define their abnormality: isolated hematuria, proteinuria, cystic kidney disease, and so on. After all, that's what the cardiologists do. Atrial fibrillation, heart block, pericarditis. They don't call everybody congestive heart failure or chronic heart disease. Age is important, and you all voted for age to be included in the classification. And this is where it gets more difficult. So, could we divide them? And these are all questions for discussion and perhaps for research over the next few years. Less than 65-year-old, over 60, tell them what's wrong with them, but don't tell them they've got chronic kidney disease. Don't alarm them because they've got isolated microscopic hematuria for all their lives. And keep this with plus or minus proteinuria. Where it gets more complicated is in the over 65, because you've got this group of age-related declining kidney function who very often have a normal serum creatinine, an estimated GFR, which should be accurate with CKD epi, and less biased than it was with MDRD, between 45 and 59. Now these have a good prognosis in the absence of proteinuria. So why tell them that they have CKD? Why tell 40% of the population who have normal serum creatinine, no proteinuria, at least by dipstick analysis, that they have chronic kidney disease? So I would put them in this bracket, and the ones with proteinuria will have moderate CKD and then severe and then end stage. So I've argued these 4 points. You all seem to have agreed that microalbuminuria in isolation is not a CKD definer, that CKD 1 and 2 distinction may yet be premature, that age cannot be ignored, and perhaps this is arguable. And I think it takes us back to finish with the 5 points. What is the purpose of the classification? Is it for nephrologists? Is it for general physicians? Is it for community-based CKD, or is it for referred CKD that we see every day in our clinics with chronic glomerulonephritis, pyelonephritis, and so on? Are the data we based a lot of assumptions solid and valid enough to come up with recommendations, or are they still subject for research? Are they useful to our patients, or is it just useful for cohort study, epidemiology, and research? Risk-benefit. There is a risk in telling 40% of people over the age of 70 that they have a chronic condition. Medicalization of aging and of perhaps normality. And there is a cost, huge cost, if 20 or 15% of the community suffers from a real disease, chronic kidney disease. Thank you very much.